projects form the basis for this pilot, Dismantling Discrimination, Racism, and Stigma Through Structural Competency, also referred to as DDRS. First is the 2016 pilot, Imagining the West Side, that can be found on my website, Place and Health WV. And second are research findings demonstrating how physicians feel helpless, burned out, or as if they lack the tools to take on the systemic, structural, and non-medical factors that shape health and disrupt the healthcare interventions and drugs that they're used to dealing with when they treat illness. To tackle these deficiencies in physician knowledge and skills, along with the barriers that make it hard for communities like West Virginia's West Side to address structural, institutional, and systemic factors, the DDRS pilot employed the notion of structural competency to help the medical students connect social determinants of health to more precise tools, skills, evidence, and data that achieve social justice and equity. I want to quickly go over the program components for the DDRS pilot. First, the pilot included 79 first-year medical students. Of those students, 64 were in-state residents, 6 students were African American, while 5 were Hispanic, 1 Native American student, and then 56 students declared themselves to be white. The training broadened the traditional health curricula to include activities that taught the medical students about inequitable institutional and systems-based programs, policies, and practices that disproportionately affect marginalized, vulnerable communities. The pilot began September 29, 2021, and ended with an assessment of the students' awareness and knowledge using a self-administered qualitative method in January 2022. Programmatic components included 8 interactive Zoom sessions, with the first on September 29th, featuring a discussion on structures and systems that influence health and ways of responding to harmful social factors. The second session of the pilot featured the Long Talk organization and an interactive discussion with the students on the history of race and racism in the United States. On October 13th, the third session featured a WVU historian presenting a critical analysis of historical events in West Virginia and how those events intersected with poverty, racism, and the state's past and present day health outcomes. The cornerstone of the DDRS pilot was the October 26th community immersion experience, featuring an interactive session conducted by community residents and leaders of the West Side, which included a walking tour of the community and a photo voice exercise. Essays were a required submission from the students following that community immersion day. Photos were optional, and we wanted to recognize that some students may or may not feel comfortable taking the photos, so the essays were required and the photos, again, were optional. Following that one-day experience on October 26, we had a 4th session on December 2nd where students met in 4 groups to review the community immersion field trip. They discussed their essays and photos, and then were able to interact with community members who were present for the debriefing. A final session took place on January 21st, featuring 3 presentations on what it takes to redevelop a marginalized community. Each session of 45 minutes featured subject matter experts on community economic development, community organizing, and experiences with housing, drugs, and the criminal justice system. To close out the pilot and collect qualitative assessment data, the students were asked to record answers to 2 questions, and this is reviewed in the last short video segment. The 2 questions students had to select from were: the first, tell a story about fixing people and places. Why is it important that we do both? Or the second question that they could answer: why would addressing cultural competency and/or medical racism be insufficient to remedy health inequities? What you see in the videos that accompany this pilot are the following. September 29th is an introduction to structural competency. October 6th is an anti-racism activation experience. The October 13th video is The River of Time and History in West Virginia. October 26th, video is a one-day photo, voice, and community immersion experience on Charleston's West Side. December 2nd is a video that reviews the students' immersion field trip using essays and photos. January 21st is Redeveloping a Marginalized Community and features a community economic development specialist. And then the last video represents the students' recorded submissions describing what it takes to make a healthy community. Now we're going to begin our review of the pilot by looking at day 1 from September 29th.
So what I want to propose to you is that right now we're kind of in a locked room. And I use this as a metaphor for the notion that in healthcare right now, we use the term social determinants of health. We are thinking about how we're going to address these non-medical determinants of health, but we kind of go around in a circle and we end up right back at what do we do as healthcare practitioners to address the non-medical determinants of health. And many of Dr. Hansen's examples try to get us out of the locked room, right? So when the locked room is the healthcare system, how do we drag ourselves out of that locked room into the community? And what we're doing with this pilot is moving from the healthcare system out into the community. And you're literally going to move into a series of exercises that helps us to think about systems change, policy change, institutional change, which requires that you wear two hats almost. And what we're thinking about with this pilot is how we merge the roles that we take on, both our role as health practitioners or medical students, and the role that we assume as members of a community, members of a society. And so at the end of the day, this pilot is presenting you with an opportunity to merge those roles. But again, it does require us to move from out of the healthcare system, out into the community, interacting literally at the community level. This is the Robert Wood Johnson Health Rankings model. What you see in this model is what makes up health. To what do we attribute population health? And what I want to call your attention to are the blue boxes moving over to the right. And you'll see health behaviors at 30%, clinical care at 20%, social and economic factors 40%, and then the physical environment 10%. And so literally what we're saying is that clinical care or healthcare makes up only 20% of what it takes to make a population healthy. And I want you to keep that in mind, right? So if we keep doing healthcare, how do we begin to address the non-medical determinants of health? How do we actually make those populations healthy that are most vulnerable? We've got to think about this differently, which is the reason for the concept of structural competency that we're introducing with this pilot.